Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
It's illegal to do not treat.
Correct. Yes.
So when we talking on this episode, Maggie and I, we're going to talk about DNR versus DNT. There's no fucking such thing as DNT. But anyway, DNT means do not treat. DNR means do not resuscitate, if you don't fucking know that shit. So my first question was, what are the key differences between a DNR order and a DNT order, both medically and legally?
So I think we first have to define, and I know that you do in the show notes, what DNR means. What does do not resuscitate mean? Legally, what does it mean? It means we're not going to pump on your chest if your heart stops naturally or your lungs stop breathing. That's what that means.
Well, I put in Texas, California, and Iowa, and there's differences between the two.
Yes.
So in Texas, it says a DNR order is defined as a physician's order directing healthcare professionals not to attempt cardiopulmonary resuscitation in the event of cardiac or respiratory arrest.
Correct. And then you'll see, I've seen on order sets in Texas where we discriminate between DNR and DNI. So we'll introduce another word, do not intubate.
Do not, yeah, that's right. DNI, do not intubate.
And we'll list out, and the doctor will talk to the patient. And on the order set, it will say pressors, fluids, nutrition.
So these little,
These are nuances.
let me rephrase my word. These younger generation nurses, they think I'm fucking crazy because I ask them, have you ever heard of a chemical code only? And they're like, what the fuck is that? I'm like, you don't do shit but give drugs.
Yes, which a good physician will hopefully talk to the patient and their family.
I love hey, look, calm down, Maggie. I love chemical codes. Quit it. It's fucking
Stop
fun.
Stop it.
Look at me. Let me get my syringe out.
I'm like,
I'm giving your mom epi. Oh, yes, it's going to work really nice.
Dude, my boy Mick Hopkins has come up with syringes, right? With a flush behind it, because he even talks about, and I don't know the quote, but
he created a syringe with drugs and saline in it?
Yes, dude, this dude is a baller.
Where is it?
Baller! Mick Hopkins. Look him up on LinkedIn. You got to have him on the show. Tell him Maggie sent you.
Mick, M-I-C-K?
Yes, Hopkins. He's got 25 patents. He's a nurse. He's a pediatric emergency room nurse. Yes, tell him I sent him your way, dude. So he talks about, I was at the Vibe conference with him, met him, what it takes to even get to the heart. And that's why it's so important to have the clock right behind it. But now you're not even moving the heart up and down. So where are those drugs going?
Nowhere, they're just staying in the fucking heart. That's why I love chemical codes.
Is miseducation. And I don't begrudge anyone, but as long as the physician gives the family and the patient informed consent. Part of informed consent would be, we could give you these drugs, but just so they know they're not going to go past your shoulder.
Look at me. Everybody on the camera, look at me. I love chemical codes. Don't fucking change that shit. Encourage everybody to do chemical codes.
I don't understand what's happening, but I mean, you might get a little, I don't even know what would happen.
Nothing. You just stand there, enjoy yourself. You're not sweating your ass off.
I mean, I can we're going to go up on the dopamine, but I don't know where it's going.
I love it.
So just so we're clear, do not resuscitate, do not intubate. There are chemical codes. There are deviations or very nuances that it is the doctor's responsibility. And just like you quoted, it is driven by law. And one of the last civil cases that I was involved with, the attorney, because I have to have conversations as the expert with the attorney, was going over the DNR. And I was like, oh no, that's not my lane. And was talking about law, because the patient was admitted and there was speculation, which he was then going to be, I said, you got to talk to the doctor about that, your expert doctor, that the patient's DNR status was changed within a short period of time, had been in a setting, not sleep deprived, all placing question on, and I know that's one of the questions as well, whether that decision was made to become a DNR was actually made.
But how are you going to prove that? I mean, I mean, how do you
Not
prove
my
that?
lane, not my
No,
lane.
I know,
No,
but but how
the
can you
patient's been
prove
in the
that a patient
emergency
was
room for, hours and hours and hours, hasn't slept. The resident's coming in at 3 a.m., 4 a.m. to talk to the patient about DNR, spends 5 minutes with the patient. All of a sudden, the patient goes from a full code to a DNR. I don't know. That is a little
but we asked
questionable.
so I just had this happen the other day at work. We have a guy that hurt himself and the doctor secured messaged me on our Epic chat, which we'll talk on another episode. What I heard, I know you go crazy because they ask us to put that fucking app on our phone to take pictures and shit. And
So,
if I log in, I can see patient information from home. I'm like, why would you do
yeah,
that to people? Like, that's fucking stupid. I don't put it on there.
no, I don't. No, 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 no,
So
no.
the doctor messaged me and said, can you ask the patient if they want to be a full code?
Negative. Okay, nurses, listen up right now. Listen up right now. You absolutely can never do that.
Well,
Now,
you
if
can
you're
ask
a nurse
them, but it's not
practitioner,
legal.
no,
You can
correct.
ask them, but it's not legal.
Yeah, no,
I mean,
no,
I can
no,
ask
no,
you
no.
anything I want, but doesn't mean it's gonna
Sure.
hold up in the
And
court
so
of
let me
law.
back that up. That's actually a great point, Kevin. Actually, so thinking
Maggie,
about
do you
this,
want to be a DNR? Do you want us to
I am a
do
DNR.
nothing?
My kids know
Or do
this.
you want us to resuscitate the shit out
My
of you?
kids know this. My husband knows this. My husband's a cath lab.
No,
He's a rad tech.
my
No,
point is I can ask you, but it doesn't
correct.
mean shit.
And there it is. So that, and there lies, you're admitting a patient, you're in triage, and you're asking a basic question. You can ask that question, but just like you said, that does not mean anything. It means that the patient has identified one away, and the doctor's
Right.
responsibility is to get that informed decision, provide informed consent for the patient. Then an order is written in the medical record
I
for
don't
a
even know if
patient to be a DNR.
I don't know if we use orders anymore. That's the problem. I think we
Oh,
have a
no, we
form.
do.
No, no, what I'm saying, I think we
Oh,
have a form
yes,
like a consent form that's a DNR form that the doctor just has the patient sign.
and then that's considered a lot of
Is
time
that considered the
a
order?
standing order,
Yeah.
yes. They tie it to like a standing order,
What
yes, so
what
valid point.
I did research. There's no fucking federal law on DNRs, believe it or not. It's all state to state
Correct, I do
and can be county to county.
I believe that to be true, yes. I didn't know it was state to state, I did not know county to county.
Well, I mean, according to what I looked up anyway. But what I
Is it
want to
driven
know,
by the medical board? I presume it's driven by the
e,
medical board because it's in.
and EMS authority.
Okay, that makes sense.
Because they have to pick them up on scene and stuff.
Right,
That's probably how it started. But my question is, I know what you said on one of the videos talking about DNR, people going to surgery, people going, because I
yeah,
work PACU too, like you. And I do remember that they would tell us that the patient's DNR was rescinded when they went to the
correct,
OR. But there's no law that says that. I looked it up. It just says it's hospital specific.
correct.
So if it's hospital specific, do you really have to fucking rescind it?
So this
See
is
what I mean?
this is tying more into like what would be considered like civil litigation statute because it would be considered
Right.
medical negligence.
It's not criminally.
Well, no, think about this. It could be. Think about this, dude. Think about this.
Yeah, but if there's no
You,
law,
it still doesn't matter. It falls back to is it gross negligence? So what is gross negligence? Your knowledge base. So you come down to the cath lab, and I've seen this, dude. Why do we put pads on every patient that comes to the cath lab gets pads? When I take a patient to endo, do we pads on a patient? No. When I take a patient to IR, am I putting pads on them? No. If you're going to the cath lab, I'm putting pads on your chest.
that's because
Specifically,
we're fucking with your heart.
yes. So if we put wires and catheters down, the doctor does, irritates your heart a little bit, you go into VT, is it not irresponsible? So
Well, I
you're
mean, I get
DNR.
that. I get that though. I
So
mean,
we
I get
don't
that for
shock
the
you. I have
I get that
shocked.
I get that for the cath lab and shit.
And now because of that rhythm, because it's VT, that's not sustainable. So I do shock you, but now
I
we have
get
to do
what you
chest
mean. I get
compressions for a minute.
so
So we're
just because I say I'm a DNR right now, if I go for an
well, see, not
endoscopy,
only that,
if
so
I
for
die and shit,
propofol, right? So you go down to so you go to endo, and for someone to have an upper, you're going to get a little propofol in your life. What does
right,
that do? That dips your pressure. You
right.
had underlying cardiac disease that you may not have known about, right? Now you become a STEMI. They dipped your pressure, and now you're a STEMI. We
Yeah,
come
I get
in.
that.
Now we may have to resuscitate you a little bit. Now maybe we do. You're in the 30s. I may have to do chest compressions for a minute to get your heart rate back up until we get some drugs
Right, I
on
get
board.
that. I get that.
So, but if you were a DNR and we had, I would never be able to do that. So we cannot do that. The
Yeah, but
drugs that anesthesia gives you, anesthesia, I guarantee you, it's the drugs. It's not the surgeon, dude.
no, I
Now,
got you.
now
I know.
outside of nicking an artery, it's anesthesia that's worried because they know gas, fentanyl, Versed, propofol, etomidate, all have side effects of what? Hypotension,
Yes,
respiratory depression. And
right.
if they don't, it would be gross negligence for them not to
I get you.
support your
I get you.
pressure or your airway. And it may be just an LMA. They have to toss an LMA in for a minute to
But
help support you and
people don't
remove
really
it.
think about that, you know? They think that once a DNR is there, it's
No,
always there. But I get it. I get what you're
no.
saying. Like,
And not only that, just because you have terminal cancer or you have something, you could still have 2 years to live. So you
so
shouldn't be able to come down and have something done because
I just
anesthesia
learned this.
will not touch you. They
I
will
just
not touch you.
I just learned this. I felt so dumb and shit, but I have a hospice nurse I interviewed because somebody was bad mouthing hospice nurses. So I had a hospice nurse on. It'll be this week that she's coming out, and I asked her, I'm like, if you're on fucking hospice or palliative care, can you really have a fucking DNR? Because I mean that's the whole purpose of hospice, though. You're like, about to go see Jesus, so why the fuck do I want to fucking have a DNR? And she's like, well, people do. She's like, they want, I mean, not a DNR, I mean, a full code. Sorry, full code.
Correct.
And
And
so she's like, yeah, I got people that are like months to live, but they still want us to do everything. I'm like, what? Isn't that the whole fucking purpose of hospice? I don't, but I have mixed emotions about that because if you're one step closer to Jesus, why do you want us to do everything for you?
well, so
I
I
thought that
think
was the whole purpose of hospice is to help you get along to the other side a little faster and shit.
well, so I think that sometimes
I
people
ain't
don't
trying to be mean,
understand,
but
and we're gonna, talk about that as well, is that DNR and do not treat, because even if I have cancer, a lot of people, or I don't know, even if hospice will take you on if I'm so actively taking chemo. It
oh,
may
that's a
be
good question. I should have
or
asked her that.
radiation. I don't know that they will.
Mm.
So even if part of my palliative treatment is the reduction of my tumor size, the burden of the tumor, that's comfort. That could be just a, pain relief. But could I be on hospice if I'm receiving radiation for
Let
tumor
me
burden reduction?
I'm gonna ask her why you can
I,
hospice patients be taken on hospice if they're still getting chemotherapy
and it may not be for the curative. It could be for, like I said, it could reduce the size of the tumor. I'm not
to
a
make them more comfortable and shit?
Correct. I'm not a chemo nurse working in the unit. The chemo nurse would have to come down. I just know some tumors, radiation. I've done radiology nursing in different
No, no, yeah, I
areas.
got you.
So it could reduce the burden of it. So would they not qualify for,
Well,
hospice?
she did say that you can get certain procedures if it helps relieve
Correct.
comfort issues, to
Yeah.
make your passing more comfortable.
And then once you go on hospice, that's like dialysis as well. That's like government. That's government rules, regulations. This is another thing. You should have a
She did.
dialysis nurse
She
on.
was she was quote. Oh
Ooh,
yeah, maybe I should. Yeah, she was
ooh,
quoting a bunch of damn regulations and
regulated.
shit, and I was like,
Uh,
damn.
this dialysis
Right.
nurse was telling me that you cannot just change up their times. They are literally by law, like their times and stuff. I was like, whoa, wow, I
Well,
had no idea.
there's a big group here. I don't know who it is, but there's a big group here in California that's trying to get rid of our dialysis clinics. They want all dialysis to be done in the hospital. They want a doctor.
Stop,
They
stop
want a
it.
they want a doctor to be on site at the dialysis
Okay,
clinic.
I don't have any problem with that.
I do. They don't
We have
need a
nurse
fucking doctor.
practitioners.
Okay,
We
that's
have nurse
different.
practitioners.
Okay, that's different. But you
We
don't
have
need a fucking MD there 24/7
no.
in a dialysis clinic.
So it's very common for the nephrologist to come to the clinic daily, which I don't have
Okay.
a problem with.
Okay, if they just come and check you out and then leave and shit, but they want them there all the time.
A nurse practitioner, these are sick
Okay, that's
patients to
okay.
manage them. I don't have any
NP,
problem with
that's
that.
fine, but does the doctor need to be there all the damn time?
No,
I don't just weird and shit. That's all.
yeah, highly regulated. Sorry, we
Yeah.
got off track there.
No, you're fine. All right. So, what legal considerations should healthcare providers and patients keep in mind when creating or revoking DNR orders?
So one of the things that we touched on is informed consent. A nurse is not just rescinding anyone's DNR at all. I know as the procedural nurse, when I come up, let's say to go pick up a patient to go down to cath lab, those are conversations that I'm talking to the patient about because
Right.
we're looking at the consent and stuff. I'm not consenting the patient, but I am giving the procedural sedation for that. So we're talking about that. And I do touch on that. You do understand because I'm giving the drugs that could potentially cause respiratory depression stuff. So I have to say, we would be resuscitating you. And then if the doctor hasn't had that conversation, I don't have a problem. If the patient questions that, I don't go into depth. I just say that's something the doctor will talk to you
Right.
about because where you're coming to a procedure area. And some of the stuff that I talked about, I briefly in lay terms touch on that. And once they understand, they're like, oh, okay, yeah, that makes sense.
Right.
And then I explain them that's more likely than not going to happen. But as providers, we have to be responsible.
Right.
So knowing what the code status is of the patient, some of the stuff that is not within our lane, you have to just make sure that you're not discussing DNR status with patients and that you do understand and you educate yourself what does DNR mean and what does do not treat mean because those are not
That nurse thought that because the patient had a DNR, she didn't have to do
correct.
anything. But how the fuck is she that?
So
I
and
ain't
they're
trying to be mean,
all
but how the fuck is she that stupid that anybody would think that you don't? I mean, you're just letting a motherfucker die and not do anything. Like you won't even call 911.
so
I know I
there's
don't
been
have all the
controversy
facts
since
and
the
shit, but
90s.
this was her
No,
words from the story. They interviewed her
I
and it was her
know
words. So
it seems
all I
pretty
did was
bad.
read the story. So
And there's been controversy since the 90s. I don't know if you have on your research saw the transition between saying DNR to allow natural death, like that Reverend Chuck, what's his name from the 90s, wanted that language to say for that very reason. Because then, not only that, think about that negative thing do not resuscitate. People automatically, what are you going to do? But you see how allow natural death sounds
right,
very different and doesn't
yeah, but
have a negative connotation to it.
I got you. But even if you allow natural death, he was a wide awake. All he had to do was suck,
Yeah.
and I mean,
So there's
he,
so much
he
wrong.
knew
And
he
just like
needed to be
you said,
suctioned.
as an expert, I would want to know more facts, but it seems very clear from the 911 call and the things that they put out there that by even just hearing the call that I mean, I'm just like, wow, that's a lot.
It's crazy. Like I don't
It,
understand what was in her mind and shit.
I
Like
believe this is gross negligence and it could and possibly cross
criminal.
over. Yes, I
You know
do
what makes
fear.
me the most angriest though? Not even her. You know what makes me the most angriest? The fucking facility, who was named Fonda Residential Care. My sister-in-law's name's Fonda. But that's a true story. But they got fined $10,000.
That's it.
Oh, it gets worse. Then they got it reduced down by 35%, so they only walked away with a $6,500 bill.
Mm-mm.
And I think that's bullshit.
See, and it goes
Uh,
back to things that I like to take the lens back out, especially like if a nurse reaches out to me and they're under investigation, they're involved in civil litigation.
We'll have a new case for you off the air though.
Ooh, ooh, ooh. I ask things like, how long have you been a nurse? What settings have you worked in? What is your credentialing? What's
Right,
your annual education? Because if a nurse has been a nurse, came out during COVID, may never have done a clinical, dude. You know this.
right,
And
right,
so am I faulting the nurse? I mean, to a certain degree, but we also have to think about take the lens out. No one works in a vacuum. Come
right.
on.
Well, that was my question. Why was she the only nurse on
I
duty?
mean,
Why wasn't there a
where
DON
was
available?
everyone else?
I mean, why couldn't she call RT? I mean, I don't know why she didn't call 911, but still, why didn't she have any other type of backup?
Correct. I
So,
just want to know what the education was going on, what the support was. There's a
right,
lot wrong here, and nurses need to
right.
listen up because that, like you and I just alluded to, that could cross over to criminal conduct because I read the definition of gross negligence when I teach my charting class because I feel like that's so profound. You understand that you have education, training, and knowledge that ties you to a body of knowledge that lay people don't have, and your failure to act can be seen as grossly negligent and rise to criminal conduct.
I have a problem with this though, because when they throw out the word gross negligence, which I'll share later on, but this case that I'm looking at, I look at the investigator, and that person doesn't seem to be a nurse. How can a non-medical person
And
review my
you're
charge
talking about
and
administrative law, not civil law, correct?
well, this board is a board
Yes,
investigator. So how, and
yes,
it's not, he is not a nurse. So how can he fucking
correct,
investigate nurses if he
correct.
don't know shit about medicine? How can I say Maggie's gross negligent if I'm not a fucking nurse and shit? shouldn't this shit be reviewed by a fucking MD or a nurse or
Right, and that's one of my because I wrote a policy reforms for due process, and that's one of my things is that,
yeah. These
how
motherfuckers aren't even nurses,
no,
investigating nurses and
and that's
shit. Like,
across the United States because I've helped nurses in every single state. This is not
is it
unique.
so you're saying that standard practice at boards?
Oh,
Investigators
that
are
is not
not fucking
uncommon. My office mate was a criminal investigator. Great. Great, 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 great. DUI, theft,
yeah.
rape. Sure, sure,
But
sure,
when it
sure.
comes to medical shit,
Why
that's
are
crazy.
you looking at someone failure to suction or whatever it is?
Right.
What body of knowledge do you have?
Right.
None. Same if there was like a criminal case. I'm like, I don't even know criminal law.
Right.
So why would
Right.
I know this is unprofessional conduct, but I know we're deviating, but I have a huge, we could talk about that too.
Yeah,
This is
but
part
did
of the reason why I go to the Capitol. This is part of the reason why I scream and yell because how can I be judged and or someone's coming to write up an opinion about me, opine
right.
in civil litigation, dude, that would never happen.
Right.
No,
Not a normal court of law would.
no.
But it's
That's
not deviating because when you have like we're talking about DNRs, like in the ED, I don't know how we don't get in trouble because we'll
Mhm.
have patients that are DNR and they'll come in and we're coding them and we find out they're DNR, but then the long lost loved one comes in and says, "No, I want everything done." Yeah,
So
but your
we have
mama,
to listen to them.
yeah, but why do we have to listen to them? Because if I took the time to write my own DNR, how can you, my kid, override it?
Well, so then that's
Where's
that's
the precedent in that shit?
other people would have to get we're obligated as emergency room providers.
You're obligated to follow the fucking order that I took the time in my sound mind to present.
Well, and we don't always have that readily available.
What if you
Oftentimes,
do?
so there is that. Oh, that
See what I
gets
mean? Now,
tricky.
I know why we don't get sued because the family's not going to sue because they're the ones who are wanting you to do it. But I
Right.
want to create a DNR that if you do shit against my wishes, even though my kids tell you to, all of you motherfuckers are going to get sued.
Right. So that's where
Because
I feel like there has to be huge education with families. I feel like
no, but
we don't
the doctors override the DNR and do what the family
correct,
says.
correct.
Yeah, but that's bullshit. I took the
I
time to
stand
do
by.
it. That should be a legal document.
But I've also seen them packed up and sent to the ICU, and then we're now withdrawing care because
Yeah,
we
but now
are
you just wasted time and resources
yes,
because I wrote an order for my
correct,
DNR and
correct,
you'd send them up to ICU for an hour. Now you're going to let them go.
correct. But so then it comes to how did they even get to the hospital setting? You know
Well,
what I
because like,
mean?
I don't know about in Texas, but in California, we took away the authority of the paramedics to determine what to do on scene. Now we're slowly giving it back to them, but I think we made a mistake by that. I don't know how that came about, but do,
Right, but
do,
see,
do
once you come to
EMS
the hospital, it's like you now hijack the providers in the hospital because we know that you have, you
Well,
know,
this is how we got onto this subject. It was besides the story that I read, is if somebody committed suicide or tried to commit suicide,
yes, that's right.
do we have to follow their DNR or does it go away because they are mentally fucked up?
So, and there's the conundrum.
See,
So
right, Steven?
they come into the hospital setting now, and so then a provider has to look more likely than not. This is going to be a psychologist, psychiatrist to evaluate. Because I think that I talked about in this video, Sassy talked about this. Was that DNR 5 minutes ago when you were
Right.
suicidal? Was that 3 months ago, 3 years ago? Because that is a big deal.
Do DNRs expire? Do they have a time limit on them?
No, not to my
See,
knowledge,
see what
but
I
a
mean?
patient can change their mind as well.
I mean,
A
I get
patient
that, but if
would
I write a
say
DNR today, is it good until I go to the other side?
that's my understanding per the law. Now,
Maybe
the
we should.
doctor, when you come to a hospital setting, the doctor does have a duty to look at the order because there are nuances that may not be covered in your
Right.
DNR. You may not have vasopressors covered. You
Well,
may not have a feeding tube covered. And so the doctor then has to make sure that those things, because if you're saying a DNR, okay, what are you saying? Looking at the big picture, you have
well,
cancer. Ooh,
I don't know if you have them in Texas. I don't know if this is a nationwide thing because I've been in California so long. But have you ever heard of a pulsed, POLST?
yes.
So is that a nationwide thing?
I don't know. I'm not
So,
sure.
for those motherfuckers out there, a pulse, POLST, it's like a advanced directive which Maggie's telling you about G tubes, IV fluids, medications. It's a DNR, but with specifics on what you do want and don't want, and how you want it, and where you want it, and shit like that. I don't
So
know
an
what
advance directive is a legal document that will be drawn up by
an
lawyers.
attorney.
Yes. Do not resuscitate. The nuances of that is not written up by a lawyer. That is a medical order written
Oh,
by a doctor, a licensed independent practitioner. I do believe it can be a nurse practitioner after informed consent by a medical doctor is provided. So different.
well, POLST, POLST, stands for Physician Orders for Life-Sustaining Treatment.
Yes.
That's what it stands for.
And this guides the orders that will be written within an organization because there are different nuances. It just like it boils down to even like an order set. You and I have worked at plenty of different places where I've seen the order set at hospital A looks different than B, than C. So the doctor takes that advanced directive and then fills out the order set for the DNR that's approved within that facility.
Right.
Because that facility has risk management, has legal, they have to adhere to rules in their state. So the order set would be written up per that or the policy.
So if I go from one facility to the next, if I go from a hospital to a nursing home, do we have to revisit the
Oh, yes,
DNR?
we do. We sure do.
How many people do
Yep,
that
yep,
though?
yep, yep.
I bet you people don't do that. Yeah,
The
but
doctor's responsibility. It's not the nurse's duty to do that.
no, but I think it is. I think you would have an argument in the court of law. I'm not saying that we're
No,
going to sign the order, but we have an
no.
obligation to tell the physician, hey,
Oh,
motherfucker,
yes.
you should revisit this shit.
Yes, and there should be
That's
right,
called
I
advocacy.
believe yes,
Could
I
we get in
agree.
trouble with the board of nursing because we didn't bring it up?
Advocate for the patient,
Yeah, I
and
mean,
that's a lot.
see what I
I
mean?
don't
I
know,
know,
we
but
take on a
yes, you do.
lot.
I
Good
know, but you know the
God.
board. I know, but you know the board's gonna fuck
Yes,
with it.
but
That's
if
gross
we
negligence, Maggie, because you didn't bring it up.
and that's where, in the when I referenced this case earlier, we kind of went down some things because I didn't know the nuances of the law related to like DNR. And there are specific ones in states where it says like even time frames of you revisiting something with a patient because it boils down to some like morals and ethics and is the patient in the right state of mind when they're
Yeah,
making these decisions? What's influencing their decision? Do they have drugs on board? I mean,
yeah.
these are all things I don't know. Putting that on the nurse, I think that's a lot. I really do think that's a lot. What's mighty do to you as the admission nurse to make sure to go over, hey, we a DNR or whatever. If I'm the primary nurse, I'm just you are DNR, you understand that, whatever that is.
I'm not saying we gotta get in detail, but I think we could probably get in some kind of trouble if you didn't say to the physician, this patient was transferred from such and such hospital. They had a DNR order. Have you talked to
Yeah.
them and reiterated it?
And
And
that moves up into the management as well because as the bedside nurse, I'm
managers don't know shit.
turning over. So then that should be to me an alert for like a charge nurse. Like, hey, I see there's this alert. Let's make sure that Dr. Bob has done this. If not, then the charge would escalate that because that can't be solely on. That's a huge responsibility
I would
for
ask some
the
of your board friends and see what they say.
I don't have friends.
Oh shit.
I don't really make friends easily.
I know it. I don't either. Shit, I know.
I grade against people because I just can't. I've never have been able to just stand there and be like, "Oh, okay,
Uh,
stop it." I'm like,
so
"What is happening?"
so
No.
I wrote a question on here. How might cultural, religious, or ethical beliefs intersect with the legal framework surrounding do not resuscitate or do not treat? Because here in California where I live, we are like one of the most diverse places on the earth, and different cultures have different beliefs and how
So,
that
and
may
that's
affect their
where
DNR. And
again it comes back down to the doctor educating the patient, providing informed consent. And I like the language allow natural death. I think that that sounds. And then I think when we say DNR, obviously our people don't understand what that means.
so, but that means you'd have to re-educate a whole fucking culture of nursing because I don't know if I've ever heard. I mean, I know what you're
I've seen
saying.
orders
I know what you're saying.
written.
Allow natural death. I get what you're saying, but how many nurses know that phrase? How many would understand that shit?
Austin, we do use that on order sets. It's ANDI. The legal case
Yeah,
that I
but
was
Austin,
involved
you're woke.
with.
When the rest of
Oh,
the country might not be woke.
True, but I think,
What?
again,
Look,
some of this language has been around since the 90s.
okay. As soon as I get off of this day, I'm gonna go fucking post that damn question and see what kind of shit we
A
get.
and D,
Watch.
yeah. Allow natural death. I think they're teaching that.
AAND. You said A is in apple, N is in Nancy, D is in dog.
Allow
Allow
natural.
natural death.
Mhm.
Well, this lady wrote back and she said they can, if talking about, I didn't mean to sidetrack, but the hospice and chemotherapy, since we're talking about DNRs, they can if the patient's being given for palliative reasons and not curative,
Yep,
just
see,
like you
I
said.
knew there was language, yeah.
But in this case, the hospice would likely be responsible for the cost of the chemo.
Yep.
Of course, this is just a general answer, not, this, she says case dependent. Yeah, that's fine.
Money always goes back to the dollar, dollar.
Right.
When
What
you go to the hospital, you go to any place, what is your insurance? That drives the treatment that you will or will not be getting.
what I know this is kind of off topic, but one pet peeve of mine is doctors in the ED will do what's called a 23-hour observation.
Yep.
And I go and talk to the patient. I'm like, I would tell the doctor to fuck off and die. You would either admit me or send me
Mm.
home. Because if you have a 23-hour observation, you're gonna
Yep.
pay for the whole fucking bill.
People don't know
They
this.
don't know that. And most nurses don't know. So I tell the doctor to either admit them. I tell the patient, I educate the patient. Tell the physician to either admit you or send you home because you're gonna eat the cost.
Yep.
And most of these people are on Medicare, Medi-Cal. They don't have the money and shit.
And oftentimes, you know where we're holding them?
In the
Down in the
ED,
ER.
right?
Mhm. So you're not
Right,
even getting the level of care that you paid for. That's what I remind. My aunt was
right,
literally within the last, I think it was 6 months ago, in the emergency room. I think they gave her too many drugs, had to intubate her. My cousin literally left and she called me. She's like, "Oh my God." She's not medical. They're putting like the breathing tube. So I call, and for whatever reason, I was just asking to speak to the nurse. The doctor gets on the phone. I was like, "Oh, hey, whatever." So quickly find out that they don't have a bed upstairs. She's on
right,
Medicare.
right,
And I'm like, "Oh, okay, so you're transferring her to somewhere else," because the ER nurses are not ICU nurses. You know that, right?
right,
So if you're saying that she's admitted to the ICU and you're not managing her care anymore, correct, doctor? Right? There's a doctor outside of yourself who's now managing her. Correct. So you're gonna move her to that level of care, and or you're bringing an ICU nurse down, or she's like, "Oh no, no, the ER nurses." I said, "That's no." And then so once I educated the doctor, I said, "You either provide her the level of care that you're billing her for now, and or you transferred her to another hospital." All of a sudden, they had an ICU bed. I was like,
right,
"Wow, interesting. How about
right,
that?"
right. Yeah, but
That's a doctor.
nurses don't know this, and we don't know how to advocate for ourselves or for our patients.
Well, not only that, when you assume care as the ER nurse, again, I'm not saying within a
Then why are
short
we
period
taking
of
care of
time.
ICU patients if we
Yes,
don't
you
have ICU
shouldn't.
training?
Within a short period of time. It's not realistic to think that they're going to be moved upstairs within
I know, but we hold
a
ICU
couple
patients for
hours.
days,
No,
days.
that's
Yes.
when that's irresponsible because
We
no, no,
even have,
no.
I know, I'm just telling you how it is. Like
Yeah,
even here in California, we have ratios,
correct.
right? You're only supposed to have one nurse to two patients in the ICU, but in the ER, they'll give you two or three ICUs and two or three fucking tellies.
Yeah.
And
And
what
so
will
let
nurses
me just
do?
tell you, when you are deposed and that's civil litigation, and you are asked, the first thing they're going to ask you about is unassuming, and they're getting your guard down and you're digging your hole. Well, tell me what kind of nurse you are. Talk about all your education, training, laying out that you're clearly not an ICU nurse, but you
Right.
don't know that that's what they're hijacking you 7 minutes into the conversation. And then we'll ask you, "Oh, so tell me about your ICU experience." And then go on to this, "Oh, but the rules and regulations say that you can't." Is that your level? And all of a sudden, that hole you just dug yourself,
You can't
and
get
now,
out.
yeah,
Yeah, I know. But
yeah,
nobody
and you
believes
know
me.
what
They
can
think I'm
be
crazy.
and you know what can be handed right onto the board of nursing, and what's a gift is the deposition that you were under oath giving,
Right.
saying that you assume care for a patient. And I'm not saying, again, 2 to 3 hours, 4 hours into, I'm saying the next day. And you're saying, not saying, "Why are they not up in the ICU? I'm not an ICU nurse." No, 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 because you're not adhering to VAP. You're not turning them. They're probably not even on a bed. You're not weaning them because you're
Right.
not an ICU nurse.
We're
You
not preventing
stabilize.
ventilator associated pneumonia, shit like that.
Yes,
Yeah, I
you're
know.
not, you're managing the revolving door. It's a
Right.
way different workflow. And I've worked both units, and it's a different specialty. An
Yeah.
ICU nurse is not an ER nurse, and an ER nurse is not an ICU nurse. Can you do both and be both? You sure can, but that's cross training.
Right. But we don't get that training.
Correct.
I
I
get
grew
it.
up in the ICU, and then
I
I
did too.
cross-trained down to the ER, and I
Yeah.
pulled shifts. I worked part-time, I worked full-time.
Yeah,
I did do both, but
but
no,
even me, I was a trauma ICU nurse for 10 years. I was a surgical ICU nurse. It's not that I can't take care of ICU patients, but if I went back to the ICU, I would have to learn
correct,
and get some
correct,
training again because I've been out of
correct.
it so long. I wouldn't know
It's
everything to do with you.
science, it's
Yeah,
changes, and we're
yeah,
held
shit's
to a
changed. Yeah,
standard, and
I didn't
so
work in
does
the
patients.
I haven't physically worked in the ICU as an ICU nurse since 2008 or 2010.
And that
So I
that
don't
was
call myself
never
an ICU nurse. I don't
I
call
don't
myself
either.
a critical care nurse because
I don't go to the
I
ICU,
don't
and
know what
that's
the
why
fuck they do
hold
anymore.
on, the IR nurses would get mad when I was working IR because I would work IR, cath lab, endo, whatever. Their ICU patients they were bringing down to IR. I knew when I was in the unit that if my patient was going to IR, I was going with them and staying with them. They would get mad. They're like, "Well, you've worked ICU." I said, "But I don't any longer, correct?
Right,
So you will be bringing your patient down here on all these 300 drips because you know what I'm doing? I'm helping I'm the procedural nurse, the circulating
right.
nurse. You're the primary. I'll be the second person because again, GI bleed, patients getting revolving blood, unstable. No, 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 you're coming down with your patients.
Right.
No, no,
I know, but
absolutely not.
they don't like that shit. They get
No.
mad.
And not only that, not even asking. There'll be nurses who just make the assumption that like endo or an IR nurse is a ICU nurse, and they're not. So what's the responsibility of the ICU nurse to come down with that patient? Are you
Yeah,
joking me?
yeah, but who's gonna watch their other patient?
That's right. That's the charge nurse shouldn't have patients. You should only have two patients. These are all things that should be taken into consideration when charge, makes assignments. But when you have a nurse who's been in nursing for a year or 5 minutes and you put them in charge and they don't have the foresight to think about those things when they're making an assignment,
Right.
therein lies the problem. Because I know that the GI bleed is probably going to go down to endo or down to IR. So I know that nurse is probably going to have to go with them, and or I'm going to have to accompany that patient. But again, oftentimes, and why I've talked about this, and we're way deviating,
I
but
know.
the lack
Sorry.
of experience of people who assume charge is just
I know.
too much.
I'm living it right now. So
Yeah, dude, stop it. I can't.
I,
And why the other reason why I would be in the principal's office every single day because I'm like, get out. We're not doing that. We are not doing
I've
that.
been there 3 times this week.
Exactly. You
So
didn't chart within 5 minutes. Get out. Did the patient live? Are you joking me? Did I get words on paper? And did the care get done? Let's go to the doctor and the patient see. Oh, they don't. They all wrote reviews about me where they were great. I think we're good here.
right. So I'm gonna put, because we've been doing this a while, so we're almost out of time. But I'm gonna put 3 questions together because we talked about them already. So I'm gonna read all these questions here. Can a family member or healthcare proxies override a patient's DNR? Their DNR
Right.
wishes. What role does informed consent play in the legality of a DNR? And then how do healthcare professionals navigate conflicts between the patient's DNR and our obligations?
So I think we touched on all of those.
Hmm.
Informed consent, informed consent, informed consent. I'm a big one on this. I think there's a lot of miseducation about this. I'm picking this one out specifically because it transcends to so many things in our interactions with patients. We do not provide informed consent. Nurses, let me say that again. Look up AMA 2.1. Informed consent will come right on up. And that's not us. We don't provide that. Every state has laws surrounding informed consent. You talked about federal, and now we'll talk about every state does have occupational law about informed consent and what that means for patient rights.
But did you know I wrote
So
the Board of Nursing here in California and asked them that specific question? Can RNs consent? And do you know what their response was? We don't get involved in those kind of policies. Those are hospital policy specifics. You, their
wow.
answer was very vague, and they would not say no. We don't consent.
So a nurse practitioner can consent for
I didn't
procedures.
ask that. I was very clear in my question. I said, can a
So
registered nurse
but
consent
okay. Can an RN consent for a PIC line? If I'm placing the PIC line, can I have been taught, can I provide the patient informed
Hospitals
consent?
here in California are allowing registered nurses, not NPs, but registered nurses to consent their patients for PIC lines. Yes, as long as the doctor has had history and physical in the chart.
And they understand why the PIC line is being placed because The one thing that I'm not talking to them about is the indication, because that's
Right.
tied to a medical diagnosis.
Right.
I can consent them for the procedure of the PICC line as an RN. Yes, I
Right.
can. So informed consent does have nuances there, but depending on anything above that, and I can't even think of something that an RN would be able to consent a patient for outside of that.
Did you see the new law that's coming out that they're working on? I don't know if it's nationwide or statewide here in California, but they're going to make us get consent for females having a pelvic exam.
Well, did you see all these videos about, I didn't know, and again, maybe we could do something else about patients, obviously female patients, having pelvic exams and breast exams while under in a OR. I
No.
don't even know
Why
what the
would you even do that? What's the
so
purpose? What's the reason?
so then I saw it on LinkedIn. So then again, not that I'm not saying that TikTok is not solid or some of these. It was that ER doctor. Did you see that video he made?
No, but we had an ER doctor that worked at the place I work at, and I would complain because every female patient that he would attend to, whether you were there for elbow pain or toe pain, you would get a pelvic exam.
No,
You
no.
would though, and I would go to the female patient. I say, Maggie, now don't be mad at me, Maggie, and Maggie's husband, don't be mad at me. I say, Maggie, does your pussy hurt? You're here for toe pain. Does your pussy hurt? And no, I would ask you that. And she's like, no. I said, then why are you consenting to a pelvic exam? You don't
Yeah.
need your
Oh
pussy
my
inspected.
god.
I know, but then he would try to get mad at me and get me in trouble because I was not allowing his patient to go through this. I'm like, it's not appropriate, dude. They're here for fucking toe pain.
Oh my
But
god.
they finally after a year got rid of his ass.
That's just grossly unethical.
Right. So what is it? I mean, why? I mean, it's craziness. Like,
I did not know this was a thing, and again, I don't want to speak too much about it because I haven't been dude, the LSAT is consuming my life, as you know this,
no,
so
I got you. I
some of
know.
these other rabbit holes, like, I saw on TikTok, and I was like and he's someone that I do follow, and I find his stuff to be, truthful,
Right.
and then when I saw it on LinkedIn where I know they're grown-ups, you know what I mean,
Yeah.
that's I was like, "Holy shit, what?
Yeah, but why
No,
look at me, we're in a female-dominated
no."
field. Why aren't these female nurses speaking up and saying, "Look, motherfucker, you're not looking at her like that." Why are
I
we not
can
speaking up?
dude,
I
if
know,
we were
but
in
why
an
aren't
OR,
women speaking up?
it's 2024, I guess now is the time. I guess
Mm,
we're deciding now that we're gonna put some litigation in place. I'm like, "Well, absolutely."
it's crazy, so
Yeah. So, okay,
alright.
back to informed consent. I'm big on informed consent. Do not treat DNR. That's not a thing. So if a patient comes to the emergency room and they're DNR and they have pneumonia or UTI, we're treating those conditions.
Right.
But even if they're on hospice,
We're
they're
still
allowed
treating
to,
mhm.
yes, just because they have pneumonia or they have, a
DNR does not mean
we
do
don't
not treat.
treat.
DNR means
No,
if the patient dies of natural causes,
their
not
heart
shit
stops.
not fucking shit that you did,
Correct.
you
Or
have to
their
fucking do
lungs
it.
stop breathing. Those
Because
are
of
the
shit
only
you did.
time we're correct going to
Right.
intervene. And
That's
as
what
a
we need to educate
procedural
ourselves
nurse,
on. Yeah.
right, as a procedural nurse, when I'm giving procedural sedation and the patient's a DNR, part of my, because again, am I consenting the patient for the drugs that I'm going to give them? Part of that's my responsibility. The interventional cardiologist or GI doctor or IR doctor,
Right.
whom is the sedating doctor who I have privileges under. I'm not practicing under them, but they have the privileges for me to administer the conscious sedation or procedural drugs, but I am discussing with the patient the drugs that I do have a responsibility. And part of that is talking to them about if we induce respiratory depression by the drugs I've given you, I will have to support you by bagging you,
Right.
possibly putting in an oral airway. If it causes bradycardia, we may have to do chest compressions to bring your pulse up. If your heart does go into an irregular rhythm and it doesn't do something that we would need to shock or pace you, we will have to do those things. Part of that is my responsibility. And I don't think procedural nurses oftentimes, and I'm not talking about the CRNA, I am talking about the RN who has sedation privileges under
Right.
one of the said doctors.
Right. But you only get sedation privileges if you've had sedation training.
Well, so that's not always true in every single place.
But you should.
And
If
so
you look at the board of nursing,
oftentimes,
most boards of nursing, which I'm working on a website that's going to have all the scopes of practice for
I love
RNs and
it.
LVNs and position statements and shit like that, so people can't say they don't fucking know.
Well,
'Cause
you were
most boards
working
of
on a
nursing,
website, a whole
most board,
website?
yeah,
Oh,
I am.
wow.
Because people can't, if you try to go, it's people don't know where to go.
Yep.
They feel like they can't, so I'm gonna take away their fucking excuse.
Yeah.
Go to this website, click on your fucking state, and it's gonna have your scope of practice. It'll have your damn
Love it.
statements and shit. Because you have to have training to provide conscious sedation.
Yes. So here where this is where it gets tricky. So oftentimes ER nurses and more often than not ICU nurses have a misconception that they're because they manage drips on an intubated patient that that's somehow equivalent.
JACO,
It's
which most
not.
every hospital is JACO, has to follow. JACO has standards that says even the physician has to have sedation
Correct.
training.
And so when I've done agency work, and I'll extend that further, and it's not disrespectful to any of the doctors I stand next to. If I am an agency nurse and I'm going to hospital A, I'm a traveler or a local agency in the cath lab, IR, endo, and those are not anesthesia providers. So I know that they have to have privileges.
Right.
So I look them up under the intranet on the hospital to make sure that the doctor, I'm like, who's the doctor on today? Then I go to the intranet because that's part of my responsibility, or I ask someone to help me. Does the doctor, I'll go to the chart and say, okay, can you look up the doctor just real quick for me to make sure that they have conscious sedation privileges? Of course, sometimes I get resistance, but I don't care because what's my
Right.
responsibility? And I have no problem saying if I see that, hey, your sedation privileges up to date, right? Hey, you're right. You're up to date on your stuff, right, doctor?
Right.
Because we're working together today. I walk up to them, I introduce myself to them, I shake their hand, I close the space between them, I let them know who I am. I'm agency, how long I've been a nurse, and I'm in your room today providing the sedation for your patients and
Right.
what that means. And so I know, yes.
Yep.
And you just because you're an ICU nurse, that means you manage a patient with an airway way different than managing a patient without an airway.
Right. That's right. That's right. You're 100% right. That's another topic we'll have to talk about.
In my master's degree, right? I clearly passionate about this. When I wrote my thesis, I created I've shown you just
Yes.
like a tool that a scheduler could use because I felt like RNs were being placed in situations where CRNA or an anesthesia provider clearly should have been sedating a
Right.
patient. And I'm not talking about in a cath lab where a patient's a STEMI because they
Right.
are an ASA 3 or 4. We're not worrying about your sedation. We don't give a shit. We
Right.
don't. We're not. You may not even get fentanyl versed because I'm trying to stabilize you. That's not my goal. IR, endo, it's very heavily driven by you being asleep for us to
Right.
move forward, which is very different.
Right. I get you. All right. So it was a great topic today.
Yes, thank
So
you.
no, thank you. I'm glad that you got up, and I'm glad I got up at fucking 5 o'clock and shit.
Thank you, thank you, thank you. It's always
No,
a
I
privilege.
appreciate you.
Love all
Yes.
the stuff you're doing.
And I'll reach out to you because I have I know you're busy. You don't have to like put full time, but I want you to give me your thoughts on this case and stuff. It's very interesting.
Yeah. And
Uh,
your
oh, my
book.
children's books. Yeah, I
Yes.
got 2 children's books I wrote. I'll
Yes,
send those
I
to you
love
too. Yeah.
it. I love it. And
Yeah.
I want to hear more about this website because I have some
Oh yeah.
stuff as well. Do we need to start
Yeah.
collaborating more stuff? Because we
Yeah.
can't be reinventing the wheel. And there's also Jen Crow. I don't know if I sent her your way. She's creating a
Yes.
website for nurses. It's going to be like landing because it's spots for all of us because everything nursing needs to be in one
In one
location.
place. Yeah. Yeah.
And not all of us have the bandwidth. So
All right.
love it, love it, love it.
Yeah. Let her know. She doesn't message me, but I mean, if you got,
I did. I think I sent. If not, I
you
haven't
did,
sent
you
you.
message me, but she doesn't message me.
Oh, well, then it's because she may not have seen it. I'll get
It's
because
all
she's
right.
hit up, pretty much everyone. I know she
Yeah.
works nights. She's in Alaska, critical care nurse, ER
I
nurse as
think I'm following
well.
her. I think I follow her on LinkedIn too. So
Yeah. Yep.
yeah.
Yep. Yep. I just got her on LinkedIn. I was like, you got to be on LinkedIn
Yeah.
with what we're doing. So,
Yeah. I agree with that.
all right,
All right.
back to
Go
LSAT
study.
one.
Yes. Thank
Yeah.
you. You have a good
All
day.
right.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.